It's so important to think about non-statin agents in pretty much all of our patients, but there are some patients where they tend to be higher risk, and those are the populations that benefit the most. So you get more bang for your buck if the patient's underlying risk level is really high. And specifically, I'm thinking of secondary prevention patients, patients with ASCVD, atherosclerotic cardiovascular disease, who aren't at their LDL thresholds and are considered high risk, as well as high risk primary prevention patients. So these are, for example, diabetics with additional cardiovascular risk factors, or patients who just have a lot of what I call target signs on them. So these are the two populations where the absolute risk is high. Therefore, the return from your investment on a non-statin agent is actually quite high as well. But again, I would implore you to think about even your statin intolerant patients, even your sort of bread and butter primary prevention patients who aren't at the target that they need to be at for their LDL cholesterol, because these are also patients who would benefit from having these non-statin agents added. Yeah, we've got a lot of tools in our toolbox, and we have to figure out which tool we're going to reach for depending on what we're trying to do. So my first thought is always efficacy. What lowers LDL and how much does it lower your LDL? So your general statin will give you about 30 to 40%. And then every doubling of your statin only gives you an additional 6% LDL reduction. So that's when you start to reach for these non-statin agents. And kind of the biggest tool in our toolbox, or the big guns, are the PCSK9 inhibitors, because they can lower your LDL in a reliable fashion about 63% from wherever you started. And they're monoclonal antibodies, so they're very targeted. And it's very unlikely to have PCSK9 resistance. But next you have ezetimibe. That's an oral agent. It's been around for a while. It's inexpensive. These are all the advantages of it. We've seen some outcomes data in the IMPROVE-IT trial as well. But that only gives you about a 20% LDL reduction on a good day. So it's not quite as potent as those PCSK9 inhibitors. And then you have bempedoic acid, which I like to say is a little bit wimpy. But if your bases are loaded and you need to bring your man home, it can get you through the finish line. So it gives you about a 17 to 21% LDL reduction, depending on whether you have a background statin or not. So if you have a background statin, I call it statin's lazy friend, because it doesn't do as much work, because it works in the same pathway as a statin. But when statins are not around, you can get up to a 21% LDL reduction. Some of the earlier trials of bempedoic acid saw perhaps even a slightly higher LDL reduction. Now, remember, bempedoic acid does reduce your high sensitivity CRP as well, just like statins do, because it works in the same pathway, whereas PCSK9 inhibitors reduce lipoprotein A, and they don't work in the same pathway as statins, so they have no effect on high sensitivity CRP. So it's always a dealer's choice when it comes to which tool you're going to use, but you need to weigh efficacy, you need to weigh safety, tolerability, and cost. I'm constantly hearing this from a lot of my primary care colleagues, which is that we can't get the drugs to the patients because they're not affordable. And so I think we really need to take a step back and take a broader look at the picture, which is really that, we're not just counting how much the drug costs, but we have to count the lives saved, the heart attacks prevented, and the strokes prevented. So I'm really hoping for a couple of things. First, as the fact that the PCSK9 inhibitors have been around nearly a decade now, hopefully the price point is going to come down, and that's going to make them easier to access for our patients, get it into our patients so we can actually reduce risk. But two, a bit of a culture shift where we stop thinking about just tomorrow and we think more about the 5, 10, 20-year horizon and how much we're actually saving the health system by investing in these types of medications, which can reduce risk, as I've talked about, of cardiovascular death, MI, and stroke. So I think that we're headed in the right direction when it comes to cost and accessibility. There is a broader coverage now for PCSK9 inhibitors. When they had first come out, it was very difficult to get our patients onto these medications. And literally they had to be having multiple recurrent vascular events in order to do that. But now I do think it's become a lot easier. In fact, even some of our patients with subclinical atherosclerosis, for example, a very high calcium score, who haven't yet had a vascular event, when you code an atherosclerotic ICD-10 code, you can get these agents covered by insurance. So I would urge you to keep trying with the insurance companies, because things have changed, the cost has changed, and a lot of insurance companies have come on board. And I do expect the future to look even more bright. So lipoprotein A is a new kid on the block. We're all talking about it. We're sort of trying to decide if we want to check it in all of our patients or not. But here's my approach to lipoprotein A. So we know that Mendelian randomization studies have told us that it's causal in atherosclerosis. In fact, it's 6 times as atherogenic as LDL cholesterol, and it causes aortic stenosis, it causes blood clots, it causes inflammation. So it's definitely a bad guy, and it's definitely around to stay because it's largely genetically determined. So 70 to 90% of our LP little a is genetically determined. There can be some variability during pregnancy and postmenopause and what have you with some medications, but mostly it's a genetic risk factor. So we're waiting to see the outcomes data from the lipoprotein A reducing agents that are out there. We have many siRNAs, we have small molecule interfering agents. We have all kinds of agents that are reducing LPA 70 to 90%. And we know that they're safe and well tolerated based on phase 2 studies. The phase 3 data is still cooking. So we'll see if actually lowering lipoprotein A reduces cardiovascular events. We think it will based on the Mendelian randomization, but that data remains to be seen. So my approach right now, before we have those large outcomes trials, is I check a one-time lipoprotein A in every single patient that walks through my door. So whether they're low, medium, or high risk, whether they have a family history or not. And that's based on the National Lipid Association guidelines from 2024, where they actually suggested a one-time lifetime check on everyone. So I would urge you to check in on yourself, your family members, and your patients, because it does a few things. It helps you reclassify their LDL threshold. So I bump them down to the lower LDL threshold if their LPA is elevated. I may start a primary prevention aspirin in older patients because we know that older patients with elevated lipoprotein A benefit from primary prevention aspirin. I may screen their family members, and so that's the cascade screening, and I may screen them for aortic stenosis. This is all while I'm waiting for the results of those large outcomes trials to be reported. I really think we need to stop thinking of just one risk pathway because we know that patients, even with their LDL-C at goal, very, very low, they go on to have cardiovascular events. So we call this persistent risk, or we call this residual risk, whatever you want to call it. The idea here is that there's multiple risk pathways. It's not just the LDL. You got LDL here, you've got inflammation right next to it. You've got obesity, which could overlap with inflammation. You've got triglycerides that are persistently elevated. You perhaps even have thrombosis as one of the parallel pathways. So I really start to think about my patients in a parallel fashion, think about all of these pathways and how to reduce their risk. We also know that the pathways work by different mechanisms. We know that agents like Visipa, as well as the GLP-1 receptor agonists, which are obesity agents and diabetes agents, all of these actually modulate atherosclerotic plaque. They change the fibrous cap thickness, they change the necrotic core, they change the plaque volume. And we know that LDL reduction does the same. The lower you get your LDL, the thicker you make your fibrous cap, the less inflammation you have in the core, the more smooth muscles you have, and the more sort of socked in you make that plaque. So I like to say they take angry plaque and turn it into happy plaque. And that's what we need to think about is these parallel risk reduction pathways, because it's not just about LDL, it's about LDL and how it interacts with inflammation, with thrombosis, with your triglycerides, and with all of the other things that are involved in the pathogenesis of plaque.